Hi guys, today I'm going to be talking about asthma and doing a presentation in response to the case study on Sarah who suffered an asthma attack. Question 1. What triggers may have been involved in this asthma episode and explain the contribution to the clinical course of this attack? Asthma triggers are factors that provoke asthma symptoms by irritating the airways. There are three causes of this attack that I have identified. The first of which was exercising without taking her preventative. Sarah's failure to take her Pulmicort may have resulted in her airways being at an increased level of hyperresponsiveness. The second of which was an allergic reaction. Asthma may be caused or worsened by allergens in which an individual has become sensitized to. Sarah's symptoms include a stuffy nose, watery eyes, and postnasal drainage, suggest that she has come into contact with an allergen. And once the allergen is in the airway is tightened and become very inflamed. The third of which was stress, and this was due to a mother undergoing chemotherapy for cancer recently. Shannon Miller, 2007, reported that asthma sufferers who experience a negative life event are 3 times more likely to have an asthma attack. Stress influences asthma by altering the magnitude of the airway inflammatory response that exercise, irritants, and allergens bring about in a person with asthma. Question 2. Describe the pathophysiology of Sarah's asthma in terms of early and late phase responses. The initial response of Sarah's asthma attack could be attributed to a combination of these triggers discussed. The first of which, exercising without taking her preventative medication first, may have resulted in exercise-induced bronchoconstriction, and this is categorized by the constriction of the airways brought on by physical activity or exercise, resulting in wheezing, shortness of breath, and chest tightness. The hypopnea that exercise causes, which is increased depth in breathing, has been shown to be the key stimulus for exercise-induced bronchoconstriction, and this was identified by Gottschall in 2002. You can see by the diagram the difference between a normal airway and somebody suffering bronchial muscle constriction. The airway is a lot more narrower. The second of which was inhaling allergen. During the course of hypopnea, it has been reported that an individual with hyperactive airways are at an increased risk for a more severe attack due to the increase in allergen load, and this was identified by Carlson et al. 2008. And the third of which was stress. On its own, it doesn't lead to an asthmatic attack. Rather, stress is a process that attenuates the airway inflammatory response to environmental triggers, and in doing so can increase the frequency, duration, and the severity of the symptoms the patient suffers. The image here shows the biological pathways to airway inflammation and bronchoconstriction, and you can see that the parts of the brain that are involved and the parts of the body and the nervous system, hypothalamic pituitary gland, the sympathetic adrenal medullary axis, and the sympathetic and parasympathetic nervous system. Exercise-induced bronchoconstriction has been thought to be a combination of two theories, and this was identified by McFadden in 1999 and Anderson 2000. The first of which was the heat exchange theory, which suggests that exercise causes a heat loss from the airways, followed by the rewarming of the airways post-exercise. As a result of this, the nose is unable to warm the volume of air, thus reliance is placed on the mouth, drying the airways. The second of which was the water loss theory, which suggests that drying of the airways leads to increased osmolality of the pericellular fluid. This is the area surrounding the cell, and this consequently results in a hyperosmotic environment in the airways, which stimulates mucosal mast cells and inflammatory mediators. It has been proposed that these release mediators result in the spasm of bronchial smooth muscle. The rapid rewarming caused by reliance placed on the mouth results in airway edema that intensifies obstruction of the airways. Dryden et al. 2010. The late response in an asthma exacerbation is associated with the second phase of smooth muscle contraction, sustained edema, inflammation of the airways, and development of hyperresponsiveness. An increased inflammatory response in the lung, permitting an influx of inflammatory cells, and these inflammatory cells release mediators that cause chronic inflammation. And you can see an example of the diagram here of the late phase asthma attack. The late phase of Sarah's episode is likely to have occurred 3 to 10 hours following her initial episode. Due to the severity of this and the possibility of her airways being subject to remodelling, it is likely the effect of the attack has been long-lasting. The chronic inflammation characterised by the late phase response can occur over a number of days, and this was reported by McFadden et al. 2000. It is a product of the cytokine and IgE immunoglobulin mediated airway inflammation response. The inflammation is caused by the induced synthesis and release of inflammatory mediators from activated mast cells into the airways. Other leukocytes to the site of inflammation include eosinophils, and neutrophils. These cause the release of inflammatory mediators that lead to the destruction and remodeling of the airways. It is the mediators released from these cells that are the effectors of chronic inflammation. Bronchial inflammation and therefore airway narrowing is a result, and this is a product of the bronchoconstriction, epithelial damage, and mucus production and remodeling of the airway. Varying airflow obstruction leads to consistent episodes of wheezing, chest tightness, and coughing. You can see here we have a small schematic of the interplay between these inflammatory mediators. If environmental and inflammatory mediators activate respiratory epithelium to release inflammatory mediators that recruit leukocytes to the lungs. T helper cells are released, differentiating into Th2 helper cells. Th2 cells induce immunoglobulin antibody production, which binds to the mast cells and basophils in the presence of an allergen, which releases mediators that cause bronchoconstriction and enhance the inflammatory response. And you can see this is in this section of the diagram. Referring down here, you can see that Th2 cells increase the eosinophil levels, which increase the amount of inflammatory mediators that are released. As they are released from eosinophils, so this leads to the increased volume of eosinophils increases the volume of the mediators released because they are released from these cells. This causes damage to the airway and remodeling of the lungs. So you can see that's referring to this part of the diagram just down here. And here's a more simplistic approach to that diagram. Basically, you can see the product of this interplay. Question 3. Based on the data provided, is Sarah's current asthmatic attack mild, moderate, or severe? The Global Initiative of Asthma 2011 has outlined criteria for considering the severity of an acute asthma exacerbation and reported that if peak flow rates are below 60% of the predicted breast on 2 consecutive mornings, then it is a determinant for a severe asthma exacerbation. Sarah's peak flow rates were 59% of her best. Kling 2007 reported in his guidelines that a person who has been admitted to emergency for an attack in the previous 12 months is at serious risk of a fatal exacerbation. Some of the guidelines proposed in Kling's article for severe asthma are as follows, and that was peak flow rates between 30 to 50%. When we spirometry assessed Sarah, we recorded 41% of her previous best. So, in relation to Kling and the Global Initiative of Asthma's guidelines, Sarah's asthma attack has been classified as severe. Based on her symptoms and previous history of hospitalisation also, and the fact that she's non-responsive to a medication. These are some of the reasons we've classified this attack as severe. Medical attention should be considered immediately. Question 4. You have to excuse my PowerPoint slides. What is the difference between Pulmicort and albuterol as treatments for asthma? Pulmicort is inhaled into the lungs. It's a preventative. In a 5-year follow-up study conducted by Buss et al. 2008, consisting of 7,241 participants, it was concluded that early intervention with an inhaled budesonide, such as Pulmicort, resulted in improved long-term asthma. Pulmicort contains budesonide, a type of corticosteroid which works by reducing inflammation in the lungs and decreasing airway hyperresponsiveness. Treatment with this corticosteroid is reported to improve lung function, attenuate the number of allergen-induced eosinophils and smooth muscle area, leading to relaxation of the airway. This helps to control and prevent asthma symptoms, as well as the airways are less likely to respond to an asthma trigger. What is albuterol? Well, it's been termed the rescue inhaler, and it's used to treat symptoms of asthma, such as wheezing, shortness of breath, chest tightness, and coughing. It is prescribed to be used as needed rather than daily. It's a beta-2 agonist medication, which works by relaxing and opening airway passages to the lungs to make breathing easier. This is attributed to the effects of beta-2 adrenergic receptors on smooth muscle in the airways. The inhaling of this leads to an increased concentration of cyclic AMP, which is associated with inhibition of inflammatory mediators released from mast cells. This is associated with activation of protein kinases, which leads to inhibition of myosin phosphorylation and lowers intracellular calcium concentrations. Drazen et al. 1996 reported that this albuterol, this beta-2 agonist medication, results in the relaxation of smooth muscle airways from the trachea to the bronchioles. Question 5. Describe changes in the respiratory tissues as a result of chronic asthma and how these changes may influence respiratory function and/or tissue hyperresponsiveness. Long-term asthma sufferers tend to suffer chronic development of inflammation that results in permanent changes of the airway. This is termed airway remodeling. Rees 2010 described these changes to be attributed to permanent fibrotic damage and an increase in hyperresponsiveness in the airways. The mechanism by which inflammation occurs are characterized by the infiltration of lymphocytes, eosinophils, mast cells, macrophages, and neutrophils to the damaged airway. Inflammatory cells cause production of inflammatory mediators. The result is increased smooth muscle mass, subepithelial fibrosis, and other structural changes. This process of the inflammation of the airways contributes significantly to thickening of airway walls, bronchial hyperresponsiveness, airway edema, and mucus hypersecretion, all of which lead to the airway narrowing. And you can see by this diagram the difference between a mild asthmatic and a chronic asthmatic. There is a severe obstruction of the airway here, which makes breathing very difficult. Hyperresponsiveness is the abnormal sensitivity or overreaction to a stimuli characterized by an overexaggerated bronchoconstrictor response. Inflammation and structural changes to the airways are the major determinants of the degree of hyperresponsiveness. These two factors have been found to be intrinsically linked. Chronic development of inflammation is correlated with permanent changes in the structure of the airways that leads to hyperresponsiveness. Holgate and Pallossa 2006 suggest that this cannot be prevented or be completely responsive to treatment. And you can see the difference between a hyperresponsive airway passage and a normal airway passage. This being the hyperresponsive passage with narrowing and restricted airflow. And here's a little bit about the histopathological changes due to the remodeling. As you can see in the epithelium, loss of ciliated cells, transformation of epithelium to goblet cells, shedding of the epithelium. Thank you guys for listening to my presentation. I hope it's been informative, and here is a list of my references.